Then comes the question on intussusception. Now adult type is colocolic, पर बच्चों में जो होता है वो ileocolic होता है. Why do you have intussusception in these babies 6 to 9 months of ages? Because at 6 to 9 months you are giving cereals, and the cereals will cause antigenic challenge, which will cause hyperplasia of the Peyer's patches. So the lead point is hyperplasia of the Peyer's patches, which will cause one part of the intestine to telescope and herniate into another. It is telescoping of one part of the intestine into the other. That's because of the hyperplasia of the Peyer's patches, which is a lead point. Other causes can be Meckel's or Henoch-Cullen purpura. In my live classes, when we take a revision program, commonest answer I get is rotavirus vaccine. Rotavirus vaccine after 6 months of age. Rotavirus vaccine, if given on time, is unlikely to cause it. Rotavirus vaccine, the third dose of it is usually forgotten by parents. If we give it after 6 months, that is when the incidence of intussusception will rise. But that's not the common cause for development of intussusception. It is hyperplasia of the Peyer's patches. Then is the classical word, 6 to 9 month old baby excessive cry. Because he's crying, sometimes you may not be able to feel that sausage shaped lump, but what will always be written will be tummy distension and red currant jelly stool. I mean, that is the key word for the question. 6 to 9 month old baby, put on complementary feeding. You have also started cereals, so there is a hyperplasia of the Peyer's patches. Cereals word will not be written. Hyperplasia of Peyer's patches will not be given. But the reason for why there is a telescoping of one part of the bubble into other is what I'm trying to explain to you. And then sometimes he will just say investigation choice, air enema. Barium enema is not done. It's only for historical purposes that you get that claw sign or a coiled spring sign for this condition, and ultrasound can be showing a target sign. That target sign, though, word is very non-specific and is read in idiopathic hypertrophic idiopathic hypertrophic pyloric stenosis as well. The treatment of choice in this condition and investigation of choice is same. Just like I was saying for meconium ileus, gastrogafin enema was the investigation and the treatment. Similarly here, air enema has made the investigation of choice and the treatment of choice as well. In contrast, intussusception that occurs in adults is of the colocolic variety. Once again, these images have been highlighted, but to contrast this with where there can be a delayed passage of meconium, and one of the reasons for delay in passage of meconium in a child can be anorectal malformation. And for this anorectal malformation, we might have to do an X-ray of the baby in inverted position, like is a baby supported on your hand, and we're putting a coin at the anus of the child as a radiological marker to check out the distance of the gas from like you can see the distal gas shadows which would be present from the anal orifice to pick up whether it's a high type or a low type of anorectal malformation. So every time we read a question about delay in passage of meconium, I mean, one of the reasons can be that the mother or the notes by the doctor or nurse do not mention passage at the time of birth. No, lots of time baby might have a meconium stained liquor. You know, especially in setting of fetal distress where cesarean is being planned, we might be having is a fetal distress. So meconium may be passed. So if there is no mention in the notes, we might, may not be able to, we might think the baby is not passed stool, whereas actually he has already passed it during the process of delivery. But assuming that the baby has not passed stool at the time of or before delivery, there was no fetal distress given in the notes, then one of the common reasons why you could be having delay in passage could be like a anal atresia. So first we will be checking the anal orifice, and we can put a red rubber catheter through the anus of the child that should pass for more than 2 centimeters. After anal atresia, an important cause which should be ruled out is anorectal malformations. In fact, even before that, another cause that I would like to write, and it would be discussed in the subsequent slide, is Hirschsprung's disease, where rectosigmoid junction would be involved, and we will be doing a full thickness mucosal biopsy for diagnosis of this condition. Then is obviously cystic fibrosis, where there would be delay in the passage of meconium. And then, like I've written already anal atresia, but like some MCQs, they may write the word ARM, that is anorectal malformations, as a broad word. And that anorectal malformation, like 1 and 4 are not exactly the same, because one is simply anal orifice atresia. Second is anal canal atresia, then is anorectal malformation, that anus and rectum, anal canal and rectum are not, like they're developed, but they are not connected. I'll say that again. Anal orifice is absent, anal canal is absent, Anal canal is also there, rectum is also there, but the two are not connected. So that's why I said the word anorectal malformation, for which invertogram would be present, would be mentioned in the question. And then you can pick up the single bubble, double bubble, and triple bubble for jejunal atresia. And this was an FMG exam question, very simple one, that is jejunal atresia, which are spotters, right? In FMG exam, there's no negative marking, so you can go on. In NEET PG, obviously, they'll go into a bit of technical aspects as well. So for IHPS, guys, it would be a first one boy at 2 to 3 weeks with a non-bilious projectile vomiting. There would be visible peristalsis and a palpable olive-shaped lump in the epigastrium of the patient. And this will be associated with electrolyte imbalances. Now, what are the electrolyte imbalances? They would be like the rationale behind these electrolyte imbalances are covered in medicine in the electrolyte section. But at the moment, the statement is sodium is also less, potassium is also less, chloride is also less. Only thing that would be given elevated is the pH. It is sodium, potassium, chloride. All three are less, and there is going to be metabolic alkalosis. The derangement is same because vomiting is present in all of these conditions. Then is mathematical values to be remembered. Pyloric thickness more than 4 mm, pyloric canal like more than 14 mm, with cervix sign and donut sign for diagnosis. And the test and the surgery that we do for this condition is Ramstead operation. Now for duodenal atresia, it would always be bilious vomiting with no abdominal distension, whereas in jejunal atresia, some amount of abdominal distension can usually be present. Understandably, the more distal part there is an option, there is like a atresia component present, the gas in the abdomen would be present in much more significant amounts. In the proximal part, well, the chances of gas will be negligible. Then the surgery that we do for duodenal atresia, like this question that came did not say double bubble appearance. Like the question said what is the treatment? So your answer would be given a DD. The older procedure was DJ, that is duodenojejunostomy, but now we do is a DD, that is a duodenojejunectomy with a Kimura diamond shape anastomosis. Once you remember that, then he will ask you regarding what is the surgery of choice for patients of jejunal atresia. Then your answer is the resection of the dilated proximal segment with end-to-end jejunostomy. So it is J and J and D, which is to be remembered for the main surgeries that would be done in this particular case. And one of the important things to be remembered is like in all of these patients, you can't operate because there is electrolyte imbalances. So a question that came in the paper was like, which electrolyte imbalance would be corrected first? Then we have to give normal saline, not obviously normal saline in children. We give N/2 saline because the amount of sodium that I need to give to a child value wise would be relatively lesser. So I can be using N/2 in 5% dextrose for this patient. And if he says what is the first electrolyte imbalance that needs to be corrected, it is hyponatremia that needs to be corrected first in this patient, not hypokalemia. We don't correct hypokalemia, we first correct hyponatremia. Then the maintenance fluid that is used is N/2 in 5% dextrose plus KCl, but KCl should only be added after the urine output is established, because these kids are dehydrated now. Because he's puking, he's having vomiting, so therefore the child is having or is at risk for pre-renal variety of acute kidney injury. If the child will have dehydration, there is less water in the body, so he's at risk for kidney failure. If you give KCl to somebody with kidney failure will also cause potassium rise, and your potassium will cause it to rise further to even cause a cardiac arrest in a person. So only after a good urine flow is maintained, that is when we add KCl to the normal saline. But initially we will be giving mainly sodium correction to this patient. And then hypocalcemia can also be present due to metabolic alkalosis. This I've explained in the electrolyte section that metabolic alkalosis or respiratory alkalosis both cause redistribution of calcium. दोनों प्रकार के alkalosis में both varieties of alkalosis will cause hypocalcemia. So if he says how do you correct the hypocalcemia, don't answer tetany. He has asked this question, how do you correct the hypocalcemia that is seen in congenital hypertrophic pyloric stenosis? There is no deficiency of calcium, it is redistribution of calcium. So treat metabolic alkalosis. You guys tell me, what is the fluid of choice for metabolic alkalosis, guys? Fluid of choice for metabolic alkalosis is normal saline. So when I give normal saline to the patient, when I treat the metabolic alkalosis component, what will happen in this case is that normal saline obviously will be, it will treat the metabolic alkalosis component, but it will treat the it will also treat the hypocalcemia component of this person. I repeat the facts again. Calcium is redistributed in both varieties of alkalosis, metabolic and respiratory. how do you manage the patient? For metabolic alkalosis, because dehydration is a cause, correct the cause. In respiratory alkalosis, carbon dioxide is lesser, so make the patient do a paper bag rebreathing. But at the moment, because it's metabolic alkalosis that is being discussed here, so this is an important concept, guys, that first electrolyte imbalance to be corrected would be hyponatremia for these patients, and it is duodenostomy with a Kimura diamond shape anastomosis and jejunostomy that would be done for the condition having a triple bubble appearance.